Hi, my name is Ken Cutbush. I'm an orthopaedic shoulder surgeon working in Brisbane. I'm going to talk to you about the risks and potential complications of the Latarjet procedure. The Latarjet procedure is an operation performed for anterior shoulder instability, so patients who have their shoulder dislocating out the front of the shoulder. It was first described by a surgeon called Michel Latarjet. He was working in Lyon in France and described the procedure in 1954. It can be done as an open or an arthroscopic procedure. The arthroscopic procedure was designed by Dr. Lafosse, who works in Annecy in France. I use Dr. Lafosse's version of the operational technique. I perform an arthroscopic Latarjet. I do a modification, that is, I perform a labral repair. So a Latarjet procedure is where we take the coracoid process, that piece of bone there, we cut it off at the base, we split the subscapularis and come in through the subscapularis muscle, which is at the front of the shoulder, and place that block of bone onto the anterior aspect of the glenoid, the shoulder socket. I fix it with 2 screws. It can be fixed with different techniques. And then I personally perform a labral repair over the top. And as I said, I do that as an arthroscopic procedure. The procedure can be done open, and a lot of surgeons do it as an open procedure. What I tell patients when we're thinking about this operation is that there are some significant issues you need to be aware of. I'm usually presenting it as an option to a patient, and we're talking about 2 options. One is a straightforward labral repair, just a simple arthroscopic procedure where I repair the labrum to the front of the shoulder with a series of anchors. And this operation was the Latarjet, which is the bone block transfer, and then I perform the labral repair over the top of that as well. The Latarjet procedure is a much bigger operation, much more complex, and consequently it has higher surgical risk compared to a simple labral repair. There's 2 things that you particularly need to know. One is there's a risk of nerve injury. Nerve injury, I quote 1 in 200 risk of nerve injury. You have to realize that could be a serious nerve injury requiring a nerve repair or a nerve transfer to correct. So it is something you need to know. There is still a risk of nerve injury with an arthroscopic labral repair, the smaller operation, but it's more in the order of 1 in 2 or 3,000. The other significance is that bone block does need to join up to the bone of the socket, the glenoid. It needs to grow together, it needs to fuse, it needs to unite. And there is a risk of non-union, there's a risk of fracture, there's a risk of complications related to the screws. All of these sort of things can happen. Beyond that, frozen shoulders are a risk. Typically in patients under 30, frozen shoulder is very rare, but frozen shoulder is a condition that can happen. If it does, it will get better and go away. It will actually help things heal up, but it can be miserable until it goes away, and it can be around for some months, 6, 12 months sometimes, if it's severe and long-lasting. DVTs, hematomas, wound issues, all of those sort of things can happen. And there is a general anesthetic, and that general anesthetic has a risk, just like any general anesthetic, and I think most of us are aware that that is a possibility. Beyond that, what I explain to patients is that I see patients for a final visit and review at 12 months post-op, and we do that with a CT and X-ray. We check that the bone block is fully united, the screws haven't moved, and there's no other issues. And at that point in time, I will assess you looking for your range of motion and any residual instability. I find about 2 to 4% of patients have problems with persisting instability. They just feel a little bit unstable. It's very rare they're actually dislocating, but they might feel like their shoulder needs to be tightened up a little bit more. And I can do that as an arthroscopic procedure. Often it's a remplissage procedure that we're talking about. The other issue is stiffness. There is a chance that patients will tighten up after this operation. Anytime you're operating at the front of the shoulder, that's a risk. You can get scar tissue. There could be residual frozen shoulder stiffness. And at 12 months post-op, that's the point in time that I will discuss with you the possibility of releasing that stiffness and freeing your shoulder up. And usually we're talking about external rotation. So with your elbow in by your ribs, you're tight going that way. And so what we do is an arthroscopic procedure at the front of the shoulder, release that and get back that movement for you. That's pretty simple. It's an overnight procedure. You don't need a sling post-op, and it's a successful procedure that's well worthwhile considering in the case where you're really tight and it's bothering you. Now let's look at put some science behind that discussion. So if you would like to look at any of these papers, the QR code, if you scan that, it will take you to the scientific article that I'm talking to you about. So the original Lafosse paper, Laurent Lafosse published his first 100 patients in Journal of Shoulder and Elbow Surgery in 2010, and that's a very interesting paper to look at. He reported out of that first 100 patients, 91 excellent results, 9% good results. 18 patients of his lost some external rotation or lost some of it. There were 2 patients that had a hematoma. He had 1 graft fracture. He had 1 nerve palsy, musculocutaneous nerve palsy to the biceps, so he couldn't lift the arm up. That got better. There were 4 graft non-unions where the graft didn't heal up, and there were 3 grafts where the graft got resorbed, as can happen, or osteolysis is what we call it. There have been 2 systematic reviews in the literature. One is Rossi et al. And the other Cozzolini et al. Rossi in 2025 looked at 5 studies, 657 patients, and found a rate of 7.5% of complications. Recurrent instability occurred in 1.5% of patients. Symptomatic hardware issues, so the screws or whatever was used to fix it, caused problems in 2.4% of patients, and 0.8% of patients, so just under 1 patient per 100, there were problems with the actual graft itself. Cozzolini, 2024, his group looked at 18 studies, a systematic review with a meta-analysis comprising 908 patients who had a Latarjet procedure, and they found a rate of complication of 14% overall. 2% of patients had recurrent instability. About 3% of patients had problems with the actual fixation mechanism, the hardware, the screws or tension bands that we use to fix the graft with. 5.6% of patients had problems with the graft, which can be osteolysis or non-union or fracture. And 0.4% of patients had an infection. So that's about 1 in 200 got an infection. This is a very interesting paper, Shah et al. In 2012. This is with JP Warner's group. He was the senior author, and they looked at 45 of their patients that had an open Latarjet, and they reported complication rates of 25%. They were very careful reporting all the possible complications. They reported small or what would sometimes be thought of insignificant ones. They were very good, very particular like that, and they reported 8% recurrent instability. They had a 10% rate of nerve palsy, and they said that almost all of those patients resolved. And in about 6% of patients, there was an infection, which is probably a little high, but then an open operation will tend to have a higher infection rate than an arthroscopic one. One other paper to look at is Gupta and Lafosse published a paper in 2015 looking at the results of arthroscopic Latarjets and including a discussion of complications. So that's a very good rundown of the potential risks and complications of the Latarjet procedure, and I hope that helps you understand this operation better. Thank you for listening.